Okay, so this is what we're going to be doing. I'm going to do a fairly brief whiz through the core principles. Phil, my colleague, will then take over talking about the relevance to social work practice, and Amanda, my other colleague, will then talk about the framework in peer work. And as we said, we hope there's going to be a little bit of time for questions at the end. So next slide, please, Phil. So what is the Power Threat Meaning Framework? If you haven't heard of it, it is a massively ambitious attempt to outline a conceptual alternative to the diagnostic model of distress. It was published in 2018. It took 5 years to produce. It is a co-produced project. So the core authorship group at the top consists of psychologists and service user survivors. And as the project continued, we drew in a number of other people, about a third of whom had actual personal experience of receiving psychiatric services. And at the bottom, you can see there's a website link. I'm necessarily going to be doing a very, very brief overview today, but everything else you might be interested in is on the website. There are talks, videos, resources, training materials. There are the PTM framework documents themselves, which are free to download. So this is a very ambitious attempt to take us beyond diagnostic thinking. Next slide, please. And it's important to know what it is and what it isn't. It is published by the British Psychological Society, but it's not an official BPS model. Not all psychologists are required to use it or to have anything at all to do with it if they don't want. It's not a way of saying everything you're doing is wrong and do this instead. It's a way of giving extra support for existing models, many of which are not particularly diagnostically based anyway. And I think that's likely to be true for many of you today. Social work doesn't come from a particularly diagnostic position. It's certainly not for professional service use only, but today we're going to be focusing mainly on professional use. It's a set of ideas. It isn't a manual to say how you should do certain things, which is why we're using today and the next session to really draw out what some of the implications might look like in practice. But it's a very open to a number of different ways in which it might inform and perhaps change practice. So next slide, please. It's attracted an unusual amount of interest. We really weren't expecting this, but there are translations in progress. I've been sometimes in combination with other people, done a lot of traveling and since COVID, videoing to a number of different other countries. It has very wide implications because, of course, diagnostic thinking is deeply embedded, not just in services, but in many other aspects of our lives. So, you know, there's a whole range of implications, not all of which we'll have time to look at today. And of course, not everybody likes it, and nobody has to like it or agree with it. There has been some not very pleasant backlash on social media, which you may have seen. However, I'm pleased to say that only last week we had a very positive article in the New Statesman, and I think Hannah's going to drop the link in the chat, outlining the framework and some of its uses. So do keep an eye on that hashtag if you're interested in following the debate. Next slide, please. So what is it fundamentally about? Well, it's about moving beyond what we have called the DSM mindset, the mindset that accompanies, supports and is supported by diagnostic manuals. The idea that various forms of emotional distress, which of course are very real, can be best understood in the same way as we understand things that go wrong in people's bodies. And of course, medical approaches to what goes wrong in people's bodies have been largely very successful over the last 100 years or so, but we actually think that we need a very different framework to understand what goes wrong in people's lives and in their relationships. And we think we need a framework that doesn't just see them as, in some senses, being hit by illnesses or disorders, which are largely biologically caused, but allows for people being active and making meaning of their circumstances and doing the best they can in their own lives. And this is not just about people who are said to be so-called mentally ill. The framework doesn't actually believe there is a clear distinction between people who are said to be mentally ill, have mental health problems, and the rest of us. The framework is actually about all of us. So you may want to apply some of the questions and narrative construction tools to yourself or to people you care for or work with or support, because they should work just as well in those situations as well. Next slide, please. So we hope that the framework not only does a better job of fulfilling the functions of psychiatric diagnosis, like identifying causes and suggesting ways forward. Actually, we would argue that psychiatric diagnosis doesn't do any of that very well. But we hope it additionally shows how even extreme forms of distress and what we've called troubled or troubling behaviour are ultimately understandable, not necessarily easily understandable, but are ultimately understandable. It's about restoring the link between distress and social injustice. This will be a very familiar idea to social workers. The idea that ultimately our personal distress or family distress or community distress can be traced back to various forms of social inequality and injustice. It's about increasing people's access to power and resources. It's about creating narratives in a very broad sense, narratives that can include things like art and music and dance and many other culturally appropriate ways of experiencing and expressing distress, which are perhaps not so highly valued from a westernized point of view. So narratives as a replacement for diagnostic understandings, and it's ultimately about promoting social action. Next slide, please. So because it's a very long and complex document, we've tried to hang it on some fairly simple core questions, which can be used, if you want, as a way of structuring a narrative that might work at a personal one-to-one level, might work at a family level, might work at a community level. And essentially, these questions help us to expand the common slogan that I'm sure you've heard: instead of asking what's wrong with me, ask what's happened to me. So moving from a diagnostic understanding to a looking at the circumstances of your lives understanding. And there's no expectation that these questions have to be asked in this order and in these terms, or these are areas to explore. They're actually overlapping questions, but nevertheless they can provide a kind of useful structure for a non-diagnostic narrative. Can I have the next slide, please? And you might want to add or perhaps start with what are your strengths, and you might want to pull together the end result in any form that makes sense to you or the person you're working with or supporting in terms of what is your story. So I'm going to talk you through these questions now fairly briefly to get a sense of what they're about. So the next slide. The first and most important question in some ways, in our view, we very much wanted to put power first and foremost in our development of the framework. Power is everywhere in our lives, sometimes obvious, sometimes less obvious. And it seems to us that diagnosis by definition excludes a consideration of power, because it's kind of saying the problem is within you as an individual, or perhaps even within your brain chemistry. But we also think that much psychological and psychotherapeutic practice excludes or at least minimises the role of power. So we're arguing against individualising explanations in general, I guess, not just diagnostic ones. And everything else in the framework follows from that. Next slide, please. So this is, you don't need to read all these tiny words. And you can have the slides afterwards, but this is one way of thinking about the many forms of power that operate in our lives. And we're used to thinking about some of these, and we're much less used to thinking about other forms of power. But it's very likely that the people we work with in services will have been on the receiving end of abuses of power in all sorts of areas, not just interpersonal, which we're perhaps used to thinking about under the heading of trauma-informed practice, which is gaining a bigger hold in services, but also more widely. So a particular form of power that we have spent a lot of time thinking about in the framework is described in the next slide, which is ideological power. We've defined this as control of language, meaning and perspective. It's not necessarily a very visible form of power, because it tends to be disseminated in the form of social norms and expectations, which we may not be made very explicit, kind of facts or so-called facts that are presented to us as natural or obvious. It's about worldviews, it's about stereotypes, it's about the way language can be used to sell some of those ideas and policies to us, often in the interests of groups that are already more powerful and to the disadvantage of groups that are already less powerful and privileged. So we would see medical model understandings of distress, and to some extent some psychological ones, as being driven at least partly by ideology, not being evidence-based, but by actually operating to support many vested interests, professional ones, business ones, perhaps social and political ones, and very often at the expense of those people who end up being caught up in the mental health or criminal justice systems and on the whole are not helped. Now that's despite the very best intention of staff in all of those systems, but if we're working in a system which is based on fundamentally wrong principles, as we would see it, then the end result is too often that people end up being long-term patients. Next slide. So many people actually are not given the opportunity or the knowledge, and perhaps don't have the confidence and the contacts and all sorts of other social resources to question the understandings of distress that are largely imposed on them in services. We tell people as though it's a fact that they have a mental illness, that it's called bipolar disorder or personality disorder or anxiety disorder or whatever. These are highly contested categories, as you may well know. At the very least, we argue that people need to be given a choice of understandings, and of course the imposition of a particular diagnostic understanding very often opens up the way for further abuses of power, for forced drugs and seclusion and compulsory admissions and so on. It's worth noting, I think, that many service user survivors, including the ones who contributed to our core author group, Jackie Dillon and Eleanor Longdon, date their recovery from the moment they decided to reject their diagnoses. Next slide. And of course, we're not saying that power is always bad. Power operates positively and protectively. We're all in the business we are because we want to use the power we've gained through our training, to support people. Necessarily in the framework, we're focusing more on the negative aspects of power. Next slide, please. And the second question follows almost automatically from a consideration of power. As soon as we start thinking about power, it becomes obvious that this can pose threats to us in all sorts of areas of our lives. I'm not going to go through this in any detail, but it's simply to note that these threats can operate in many, many areas in our lives. Again, some of which we're more used to thinking about, some of which we're less used to thinking about. And the next slide spells this out. So this is again expanding on the notion of power, and it's showing how it can operate in all sorts of ways, including more subtle ones, like we're back to ideological power again, the opportunity, the support we have to make our own values and meanings out of our lives and out of our distress. Next slide, please. The next question is a very central one because of all of our experiences are filtered through the meanings we make of it. And as if we're therapists, then what we're essentially doing is helping people to construct or co-construct meanings, but we may still be doing that at a rather individualistic level. So the next slide is emphasizing that actually we need to think about meanings at multiple levels, not just about, I feel ashamed, I feel guilty, I feel bad, all the meanings that are very commonly held by the people who come to us for help, but also held more widely in society, and none of us are free of these kind of meanings. And in thinking about them, we need to think more broadly than just, these are individual cognitions that need to be shaped or corrected in some way, but to think about, well, where do these come from? Which necessarily means we're thinking about wider discourses in society, the things we're encouraged to believe about what it is to be normal or to achieve or to be successful. Many of those meanings, again, being driven by wider interests. And of course, particularly for young people, these meanings are massively promoted through a bombardment of messages, often quite unrealistic ones, through social media particularly. so that people, particularly young people, may be given quite unrealistic and rigid ideas about success and achievement and how they ought to be living their lives, looking, feeling, behaving, and so on. And the framework, we think, offers a way of thinking about distress that can arise in the absence of what we might classically call trauma, because it's certainly the case that many people who've had more comfortable lives and come from loving and supportive families can still experience extreme distress, and we would locate that in framework terms, in terms of the more subtle pressures that come from expectations on all of us, growing expectations, I would expect, which leave more and more of us feeling that we're not doing well enough. Next slide. So the framework then goes on to consider what in psychiatric terms are called symptoms, what in framework terms we would call threat responses, which of course are biologically based. A lot of this comes from trauma-informed practice. The framework certainly doesn't deny that our bodies have a role, but that's true of all our human experiences. And we see our bodies as enabling and mediating the expression of distress and the healing of distress, not as in any simplistic way causing it, as in low serotonin causes my depression and so on. So threat responses in the framework also includes things that aren't classically seen as symptoms, because they may be socially valued, but all the same they may be harmful to us as individuals. Let's say working too hard would be a classic one that is socially reinforced, but may also be unhelpful for us as individuals. Next slide. And so we get to a very core purpose of the framework, which is restoring the links between threats and threat responses. Or to put it another way, restoring the link between distress at all levels and wider issues of social inequality and injustice. So this is reversing the process that too much psychiatry and psychology engages in, which is about severing that link. We want to put that link back in such a way that we can no longer fail to notice it. And if you're constructing a story with someone, by the time you get to this point, we would hope it becomes very much clearer why the so-called symptoms or threat responses have arisen in the context of the threats and the power abuses. I'm going to give you one very brief example of this, if we can look at the next slide, which is the current message we're all getting about how, unfortunately, hot on the heels of an epidemic of a deadly virus, we are facing an epidemic or a pandemic of mental health problems, which seems very bad luck. Possibly not a coincidence, because actually, if you look at the research, you will see that people who are suffering most through COVID and the pandemics and the lockdowns, and of course some people have suffered a great deal, are those who are facing much more difficult circumstances. They're people who are locked up at risk of domestic abuse, who are in financially extremely uncertain situations, who are at home without childcare, who are facing the very real threat of physical illness and bereavement, who are frontline workers. These people have not been, unfortunately, hit by a mental illness. These are people who have very good reasons for struggling more. And the answer is not, as we're so frequently told, in the mass expansion of mental health services, although of course mental health services are understaffed, but ultimately the answer can only lie in, the fairer society that we do have a chance to create, I hope, if we learn the lessons from COVID, in giving people financial security and making sure they have the support they need. So I wrote an article about this saying what we have to fear is not a pandemic of mental health problems, but a pandemic of mental health thinking. Next slide. So the framework also offers a way of thinking about ways of understanding distress that are not dominant in Western cultures. They may exist in parts of Western cultures and countries, and they exist to quite a large extent outside Westernized countries, and are traditionally seen as somehow less scientific, or perhaps less valid in some way. And in fact, the global mental health movement is, I think, very regrettably exporting diagnostic models across the world. And it seems to us, as authors of the framework, that a perspective that has failed fairly comprehensively in achieving recovery rates in Westernized societies is not likely to do any better in non-Western societies, where There are, interestingly, many approaches are actually narrative based and are culturally appropriate and can be very significant forms of healing in the cultures in which they're developing and have been developed. And the framework would take an attitude of respecting and supporting and perhaps working alongside and even learning from these perspectives rather than seeking to impose a diagnostic model. Next slide, please. And the framework would also emphasise the importance of going beyond the traditional causal factors in distress, beyond the things that as social workers and related practitioners, I'm sure you're well aware of, the existence of trauma and poverty, inequality and so on, to look at things that go further back and are particularly influential in certain less privileged groups, often Indigenous communities, for example, histories of colonisation, intergenerational trauma, ways of thinking that in westernised cultures we largely seem to have forgotten, very much to our loss, I think, the idea that individuals cannot be separated from the social group. The idea we need to integrate mind, body, spirit and natural world. The idea that we need to have a wider range of psychologies and research paradigms to call upon. The idea that all sorts of long-standing culturally supported practice, his rituals and ceremonies may be just as valid and possibly more so and more effective in understanding and healing from distress. There's a link there to a blog which you might be interested in reading, which describes my experience of introducing the framework at a workshop in Auckland in New Zealand when I presented it alongside a parallel presentation by people from Maori heritage in New Zealand, and how we interestingly found that at a very core level in terms of power threat meaning framework, power threat meaning threat response aspects, we could see parallels between the narrative-based understandings that are helpful and traditional in Maori cultures and the ones that the framework offers in a rather different way. So an interesting compare and contrast approach, which I think indicated that we have a great deal more to learn than to teach in some ways in our Western understandings of distress. Next slide, please. So this is my final slide. Returning to the core theme of narratives, which is a dominant theme in the framework. Storytelling and meaning making are universal human skills. In making sense of distress, we draw on something that we all do naturally. We don't necessarily need professionals to support us with this, although sometimes we do. The framework provides evidence for the central role of narrative of all kinds as an alternative to diagnosis. Narratives can take place in all and be presented and developed in all sorts of forms and formats. What we're looking to promote is the restorative power of truth-telling, and in the words of two survivors of psychiatry, recovery is a process of reclaiming our experience in order to take back authorship of our own stories. Thank you. Very quick whiz through, I'm afraid, and I hope you're able to make at least some sense of that, and it's a lot to get your heads around. I would encourage you to follow up the resources if you want to find out more. And I will now hand over to Phil.
Hi, hello all. This is it's nice to be with social workers, even if I'm not in the room with you all. So just to quickly introduce myself, so I'm Phil Wilshire. I'm the head of social work for a mental health trust, Avon and Wiltshire, and I had some involvement with the power threat meaning framework, very little, tiny bit of involvement, of which I was a great pleasure. So I'm going to talk about, do you want to go to the next slide? Thank you. So what is the relevance of the power threat meaning framework for social work? So just first of all, just say, when I've talked about this to social workers, generally there's a lot of positivity, particularly around the idea of power, and how that it centralizes the idea of power. And if there is some negativity, which there has been amongst some people, it's along two lines really. One is, well, it works fine as it is. We've got the biopsychosocial framework, and that makes sense of everything. There's a place for social work in that, and I'll talk about that in a bit later on. Or they say, what is what social work does already? Now, I think there's a yes or no answer to that. Do you want to move on to the next slide, Phil? Cheers. Well, yes, yeah, to an extent, all the ideas do chime with social work. As Lucy said at the beginning, it's a conceptual alternative to diagnosis, bringing together. There have been lots of ideas within social work itself, and I'd very much recommend you, if you've not read Jerry Chew, who talks about social approaches to mental distress. I won't go through that, but just these ideas are there, but the power threat meaning framework is bringing some of those together and does make sense to social work. And I think it's a positive thing. Do we want it to not make sense? It sits within our practice very nicely. So let's just explore a bit what it is that social workers do. As I didn't say at the beginning, that my background is almost entirely within mental health, and I'm an AMP. So apologies. I realise there's a lot of different social workers here, but the ideas do apply. But I will probably refer to adult social work more often. But it does cross across. Let's move to the next slide, Phil. So let's think about what social work is before we think about how power threat meaning framework might be relevant to it. So this is the global definition of social work. When you look at it, it's not talking about illness, it's not talking about disability. It's talking about to admit that person, I can't read the slide. That social work is it's about promoting social change. It's about social cohesion. It's about empowerment. It's about liberation. It's about social justice. It's about human rights. And so let's move on to the next slide. So let's hold those things in our head about this is what social work is. This is where we're working. So this is the knowledge and skills statement for social workers with adults. Again, we're talking about person-centered. Within that, we're seeing that social work is also the extent in this interface between empowerment and state control. I suppose we're agents of the state. We're balancing this within safeguarding within mental capacity. Let's move on to the next slide. So just trying to think about what social work is doing in this country. So this is the role of the social worker in adult mental health services. So there's again this balance between statutory duties and also promoting recovery and social inclusion, working productively with communities, leading the approved mental health workforce. So there's this balance of activities. So let's just those are the kind of things we're doing. Let's have the next slide, Phil. So this is the service user view of what social work is. Again, it's saying what people value is the relationships, the warmth, the respect, being non-judgmental, listening, treating with people in equality, being trustworthy, open, honest, reliable, and communicating well. So let's see whether working with a power threat meaning framework, do we need it? Does it add to that? Does it sit with it? So let's take the next slide. So here we go. So let's there's a picture of a fish. So let's just think that fish is it's like a social worker, it's a person, it's where we are. And so it's a metaphor, isn't it? What's the water around the fish? The water, you ask the fish about the water, they don't even know it's there. So what is it that we swim around in all the time when we're working as social workers? Well, it's this set of ideas which are everywhere, which we sometimes don't question. And those ideas sit within the statutory framework to a degree, which I'll explore in a moment. But those ideas are essentially constructs around illness, around disability, around impairment, around mental disorder, around treatment, around biochemical imbalance, around relapse. And those are the ideas that Lucy talked about earlier as being the DSM mindset. Now, those ideas are absolutely written through our statute like a stick of rock. And that is the statute that we operate with when we're working as social workers. These ideas are everywhere. Can we move on to the next slide? Thanks. So what I talked earlier about social workers saying, well, we work comfortably in mental health within the biopsychosocial framework. And I think what I would say is that's very convenient. It makes it look like we're all working in the same model, and it ignores what is a fundamental conflict. So there is a disconnect between the kind of things we talked about in terms of the definitions of what service users value about social work, about the international definitions, all the things about social justice, warmth, respect, listening, empowerment, social inclusion, and the language of the statute that we work with, which is all about mental disorder, mental impairment, mental illness, handicap, even relapse, treatment, long-term health condition, disability. So all those things sit, and we're working between those two things. Now, does that Does that matter? How do we work across that? We all find our ways as social workers. I mean, I work with a lot of newly qualified social workers coming into mental health services. Do you want to say struggle, first of all, of finding out what it means to be a social worker with all these new ideas, and people become disempowered and feel that mental illness is it's a speciality. There's expert-based clinical treatment. So what can social workers offer you? So our offer is often devalued. So what does the power threat meaning framework help us to do? Let's have a look at the next slide. I don't think it says very much. So this, oh, it does. So this is just to recap in case people were new to this. So the power threat meaning framework is talking about what's happened to you, about power operating in your life and in various ways. How did it affect you? So what kind of threats? What sense did you make of it? What the meaning? What did you have to do to survive? So that's a framework which encourages what the service user valued early on about a discussion, about a narrative. So let's move on to the next slide. And I think that's just about a case example. So I just wanted to we're going to explore these more in the seminars, more different examples. So I've explored, this is an example. Just say you're working with the Mental Health Act. So you're an AMP taking a referral, and you get a referral that says, as it might say very boldly, something like, Black British man, 22, has schizophrenia. There might be a reference to an abuse history. They'll say they're with an early intervention team. Medication was maybe making them put on weight, so they wanted to stop it, and they relapsed, and now they're getting symptoms of delusional beliefs about the neighbours. Okay, so that's the kind of referral that comes in. So what difference does it make if you start from a basis of, I'm going to work within an alternative model? Well, the first thing is it gives you permission to move things out straight away. So I've got absolutely no interest whether people say he's got schizophrenia or not. I really don't care. All that means to me is there's some contact with mental health services. I'm going to move away the idea of relapse. I don't want to think about that. I'm a social worker, and that's not within power threat meaning. So it gives you permission to take symptoms out. So whatever's happening to you, you don't need to think about it in terms of symptoms. So it gives you permission. And then let's take the process through. We haven't got long, but just before the assessment, during the assessment, and after the assessment. So what difference does it make? Well, before the assessment, it's going to mean that you're going to explore more through reading the notes and understanding what the situation is, what has happened. Now, clearly in this person's case, you would find out, what does that abuse history mean? And let's just say in this case, it meant that actually it was abuse by a teacher in a school. It was a huge impact on this person's life. And interestingly, it wasn't mentioned that much in the referral. Does that matter or not? Well, let's see. So then you're thinking about power. It's a power threat meaning. So you're thinking about power, and you're exploring and looking for what might be there maybe during the assessment. Okay, so you've got doctors there, you're there. Clearly the doctors are within the act. They're looking for ideas about mental disorder. What can you do? So if you're working with the power threat meaning framework, it just gives you permission to do the things that a good social worker would do in that role anyway. So you're going to give people a chance to tell your own story. You're going to be very aware of the power of what you're doing. You're not in a therapeutic situation, but that doesn't mean you should ignore the fact that this historical abuse took place. It's interesting about how far you can go, and you can recognize that something has happened in the past and allow that to be talked about. What does it mean that he's a black man, 22-year-old man? What's that experience of power? How's that affected him? Now, what you're doing is you're thinking that things might be, and you're allowing the story not to be shut down, which is what an illness model will do. I remember supervising a nurse when I was in a team, and I would talk about someone being, she'd say someone was depressed, and I'd try and say, well, what was that about? And she'd say, well, they're depressed. And I'd say, what's happened to them? What's going on? And she'd say, they're depressed. So it does shut down the conversation. So during that assessment, it would give you permission to talk about things in different ways and find out what has happened, what is happening, what's the social context, all things that the AMP role would encourage you to do anyway. But by not bringing illness into it in your thoughts, you're allowing yourself a broader based discussion about what's going on. Okay, then in terms of outcome, well, the outcome may very well be the same. This person, just say, I didn't say that, but he was drinking bleach. He'd done it on several days. There was a high risk, and you could see that risk couldn't be managed. You may very well think that they need to be in hospital. Okay, so the outcome may very well be the same if you think of outcome being that thin. But then the question is, what do you say and what do you pass on? So you talk about what has happened. You encourage the next part of the chain to talk about as what happened. You encourage him to be thinking about what is happening to me is a meaningful response to what happened to me in the past, maybe what's happening now. I'm having these beliefs, but my medication was stopped. But maybe what was my medication doing? Maybe it was helping to dampen that down. I responded in a way that anyone would have responded to the situation. It gets away from the idea like I am an ill person. I have got schizophrenia. I stopped taking my medication. I relapsed. I'm going to be on medication for the rest of my life. So it gives you permission just to look at things in a different way. We have hyper awareness of our own placing there in terms of the power we're using and how that may have an impact, and we're passing that on. Let's just look at the next slide, Phil. Thanks. So does it matter? So these are some. So within that, does it matter if we usually use an illness-based context? Does it matter? Well, not making the context explicit is profoundly political, as Mary Boyle said. If you're ignoring the impact of poverty, race, and inequality, which is what we do if we say someone has got schizophrenia, they've stopped taking their medication, they're relapsed, they need to go back into hospital to take their medication because it's stopping schizophrenia. We are completely ignoring the context. It's ignoring anything that's gone on where there's a link between social injustice and personal distress. It completely takes that out of the picture. And that leads to a social policy response where there's a focus on, this is what Lucy was talking earlier, really about a focus on supporting vulnerable, treating the ill. And really what we should be thinking is about helping people address what is going on, what the material circumstances. An example of a policy response, say, is in the 5-year forward review for mental health a while ago. It talked about an epidemic of depression in care home residents. And the policy response was, well, we are clearly discriminating against older people by not giving them enough treatment. Whereas I would say that this policy response would be, well, what's happening in our care homes? But that isn't where it leads you, because it gives you blinkers. Another example is about making online CBT available to people who are unemployed. This idea that what they need is treatment. It slips into our social policy. So just the next slide, which is the last slide. So just things that might be done differently generally, which is every discussion about distress has its centre the idea that people's feelings and actions are consonant with their past and present experiences. You don't take it out of people's own stories or what's gone on. It's really important. It's become a bit of a saying, but talk about what's happened, not what's wrong, and at multiple levels. What happened a long time ago, what's happened now, what's brought you to this place, and creating an idea that anyone would have responded to that. It's not that you're a vulnerable person. If anyone had been through those same events, they may very well have reacted in the same way. Reclaim ordinary language. It allows us to talk about what you're experiencing, not using diagnostic terms. Although sometimes there's no power to make these changes, they're big things. It's tempting to move to simple answers, which is often a pill. But even if you can't do anything, just an understanding that mental distress is based on social context can offer people new ways of thinking about themselves. We have to address the injustice that lies underneath. Work with co-produce with people, redefine professionalism, redefine what social work means, speak to service users, share power, and take a stand. And that's the end. And that was ridiculously whipped through. And I hope, and looking forward to exploring it in more detail at the seminar. And I'm going to pass over to Amanda.
Thank you, Phil. So, hello everyone, just a quick introduction. My name is Amanda. I'm a care experience trauma survivor who's been on the receiving end of social work for quite a large chunk of my life. I'm also a campaigner and activist on Twitter. I co-founded the peer support group, and I'm also a lived expert practitioner on the PTMF working party and provide PTMF training. Next slide, please. So I just want to give you kind of a different perspective on how we use the PTMF. So it's not, you probably might not find as much academic language in my presentation, probably find more normal language. So I'm not as polished as Phil and Lucy. I often prepare notes, so excuse me while I read from something I've already pre-prepared. So never been afraid to draw on the power of my personal strengths to champion causes that advocate for the rights of others. I've often been labelled a crusader, but I'll take that as a compliment, because fighting for survival is all I have ever known in order to live through a lifetime of trauma, abuse and adversity. Part of that horrifying journey involved learning to circumnavigate harmful institutional and systemic abuse in early childhood. But thankfully, early maturation generated independence, knowledge and skills beyond my years. That liberating resilience and self-determination has persisted across the life course and was the motivation that spurred me to respond with decisive action when the doors of Booth Park Hospital in York were abruptly closed by the Care Quality Commission in late 2015. Crucial supportive peer and professional connections that were often the foundation for relational healing were unexpectedly and without warning completely severed. The injustice of inaccessibility to services left many of my most vulnerable peers completely isolated and alone. This prompted the activist in me to initiate the co-creation of Your Peer Support, which is a grassroots trauma-informed survivor-led organisation established in mid-2016. The trauma-informed peer support ethos is to offer alternatives to the medical model of mental health, which pathologises behaviours as symptoms and fails to consider what might have occurred for someone to act in a particular way. However, from the outset, I was acutely aware of the prerequisite for lived expert skills that would empower and support peers to move away from pathologising regimes in order to support them to make better sense of their own experiences and facilitate healing. By 2017, a seismic shift in mental health had begun towards transformational trauma-informed and non-diagnostic approaches to human distress. And throughout this time, I'd been following the trauma-focused work of Lucy Johnstone after being introduced to her work on formulation during university studies. The publication of the Power Threat Meaning Framework in early 2018 sparked my curiosity of how it might guide trauma-informed peer support practice. Next slide, please. I first utilised the framework independently to script my own narrative as part of a lived expert presentation. The move from having my life story imposed by others to independently writing my own account of my experiences using my own words was so profound. It was a real eye-opener to suddenly have a conceptual framework that connected the way power had operated throughout my life. The reality was that a lifetime of being subjected to a myriad of power differentials and being the subject of abuse of power gave real clarity to the subsequent meanings and survival techniques I employed as a consequence. Although this elicited a whole range of emotions from anger to hurt and great sadness, utilising the questions in the framework on my own without input from anyone else allowed me to begin to understand my life in a very different context. The framework validated what I had actively campaigned against for years, that I was not severely mentally ill, that there was nothing wrong with me, nor was I experiencing untreatable character deficits, but my responses to the horrors that had occurred in my life were normal human reactions that anyone in that position might experience. As the weight of responsibility for the trauma that I'd endured shifted back to its origins, so did the focus. The links between my distress and the circumstances of my life, which is what had happened to me, gave clarity, and so new meanings began to develop. The transference away from my brain and my personality back to the people and systems that were responsible for years of cruelty that led to my suffering and misery was truly life-changing. Impressed at this huge conceptual shift and how easy the PTMF guided discussion and template were to use without the support of any professional, this encouraged me to canvass peer group members' views about adapting the framework for its use in a peer-led environment. The session was set up so everyone was supported by a relaxed environment for what I anticipated could be an emotive discussion. Encouragingly, peer group members were really keen to learn about the framework and to develop an understanding of how power imbalances, threats to safety, and the meanings formed from life-changing events that might be at the root cause of their distress. The core questions were presented on a flip chart for the whole group to view. Based on the guided discussion structure, one peer member presented the session with another facilitating the discussion. Each question was carefully and sensitively explored in turn. The discussion was welcomed and group members were keen to adapt the questions to the supportive peer-led arena. This provided a foundation from which to begin to conceptualise past experiences, and members shared their own personal experiences of childhood trauma and other kinds of adversity, reflecting on how this had impacted them throughout their lives. In peer support, the aim is to normalise what has been labelled as abnormal by others, because people who have been disempowered often struggle to develop meanings to their experiences. It can be difficult to make sense of unpredictable and frightening life experiences, especially when a person is struggling with the psychological and emotional impact of trauma, abuse and adversity. Yet one peer who shared their experience of growing up in an unsafe environment and the trauma of witnessing domestic abuse as a child began to understand their reactions to the devastating circumstances that continue to cause distress in adulthood. By sharing their powerful story utilising the PTMF, they were able to translate those horrifying experiences into a more meaningful context, rather than a meaningless psychiatric label that had been assigned to them based on subjective opinion. It was emotive to bear witness to a peer developing their own account, using their voice and their own words, which cultivated meaning to their pain in the restorative context of what had happened in their life. It's truly uplifting when peers make the connection between past experiences and difficulties in the present, because this puts the root cause of their distress at the centre of their thoughts, feelings and responses, rather than focusing on the unjust belief that there is something permanently and organically wrong with them. It's a bit like watching a butterfly emerging from a chrysalis. Next slide, please. We were excited to discover a synergy between the framework and trauma-informed peer practice, which is based on empowerment and understanding the role of trauma in people's lives, because one of our main organisational focuses was the elimination of power differentials that are inherent in services and clinical relationships. The integration of the PTMF principles with trauma-informed peer support addresses relational power disparities because it puts power first and foremost, which enabled us to create an environment where the understanding of the operation of power and threats this poses is paramount. Integration of the PTMF in the safety of a trauma-informed peer-led environment provides us with a robust structure and new opportunities to find new ways of understanding our lives while providing a vigorous foundation for supportive reflection on distressing life circumstances. Whilst peer support practice encourages us to form relationships outside of the context of mental illness, the framework empowers us to engage in dialogue about the lasting effects of trauma and abuse we have endured. Although we actively listen and bear witness to one another's pain, the PTMF supports us to carefully inquire what has happened to our peers, and we can share new ways of hearing those personal accounts without judgment. Although storytelling may elicit anger and other distressing emotions, by validating and normalising emotionality as an understandable response to the cultivation of new meanings of life experiences, we begin to take back the authorship of our life stories. We also distance ourselves from the ideology of disempowering medicalised regimes that require our bodies to be understood under the powerful control of others. The combination of the framework and trauma-informed peer support creates a stronger emphasis on redressing power differentials because it encourages survivors to transform imposed meanings that were made for them by others and put their past into a more meaningful context. It's truly emotive to bear witness to the evocative change from deeply stigmatising shameful false narratives of psychiatric pathology that thwarts healing to the transformative self-directed process of meaningful empowerment and storytelling that augments healing and hope. Next slide, please. Oh, sorry, I think I've skipped one. Oh, no, I haven't. Sorry, it's okay. This is also evidenced by other peers across the globe. And Hannah Komatsu, peer worker based in New Zealand, so eloquently states, and I'll quote from her slide, "Power discussions are some of the most heartbreaking but also exciting to facilitate. Heartbreaking because it can be really hard for people to suddenly experience the realities of how power is negatively operating in their lives. It genuinely is like watching the sunrise over the hills as they connect the concept to their own lives. In each group, there has been at least one person who experiences a fullness of anger over the following week as they come to terms with seeing the oppression in their lives, presently and/or across time. However, it's also exciting in that people start to shift the responsibility from themselves and their bodies back to the situations they faced, and if this includes harm from people, to those that have acted towards them. You see some people literally sit up straighter. Next slide, please. Adapting the framework for use in peer practice empowers our peers to self-educate and self-advocate. Our lived expert peers often commented that the framework made sense because it enables self-education that generates meanings, which may take years to develop within the confines of the therapy room that is not so easily accessible to many. With the advent of time-limited psychological therapies such as IACT being the only option available for many, in the age of a pandemic, which is the source of acute distress and suffering for countless people, it's vital to create supportive communities where people can create their own narratives and share stories of trauma, abuse and adversity to understand their world and experiences whilst being supported to find new ways of responding to threats to their survival. The framework is applicable to many forms of adversity, even where there's no history of overt trauma, as you saw earlier from Lucy talking, such as isolation in the pandemic, sudden unemployment or homelessness, stigma and discrimination, or even adapting to life-changing circumstances such as health difficulties. We believe that integrating the framework into a trauma-informed peer-led approach achieves this. And I hope you enjoyed learning about a different way of applying the framework.